director of the HIV/HCV Resource Center, which is a community service organization located on Mechanic Street in Lebanon. It's a little cozy, circa 1960s home that's been converted into a community service hub. It's been around, just a little background on the HIV/HCV Resource Center. It's been around for about 30 years, at least 30 years. It started as a peer support resource center, really in response to the HIV crisis that was happening at that time. So it's also known as H2RC, so that's how you can refer to it throughout the talk. So with grants and state funding really operating on a shoestring budget, Laura leads the charge in this resource center that provides intensive case management for people living with HIV/AIDS. It provides HIV/HCV testing and referral to treatment for individuals at high risk for contracting HIV and HCV. So that includes men who have sex with men and people who inject drugs. The center also provides all kinds of prevention and outreach education in our rural New England areas. I'm talking about it because a lot of people don't know about H2RC, and it's just doing super work. It also, Laura and her team also run the local needle exchange programs, which is what she will talk about here today. I think the agency's been running the program. Laura's been running the program in Whitewood Junction to the Good Neighbor Clinic since about 2010. And then she launched the Springfield program just in 2017. And is also working on a collaboration with medical students, Geisel medical students, to hopefully launch another needle exchange program in Claremont. So we're very excited to learn more about that. Laura has a BA from Colby College. She has a MA in anthropology from Boston University, and she is she's using her anthropology skills in all kinds of ways now. What people may not know about Laura is that she is a fabulous jazz singer, and so you have to keep your eyes open to see where she might be. Could find her doing her thing, and she's also a fabulous ice hockey player. So with all that, Laura.
Thank you. Thanks, Sarah, for that really nice introduction, and thanks everybody for having me talk today. I really want to get the word out about our programs, because it's true that not a lot of people know our agency, and I'm just trying to figure out how the clicker works.
You should just be able to click it and it'll go.
Just anywhere.
Turn it around.
Over here.
There you go.
Oh, sorry, I'm a Luddite. Okay, there we go. And thank you. I have no financial disclosures. I'd like to thank the Dartmouth Institute MPH program students that I've had. Blake Kruger was an intern for us last year, and he developed 2 surveys for our Syringe exchange clients, one on unmet needs and the other on overdose patterns. And so we've just started implementing the surveys, but we're looking forward to getting more results. We think it's going to help us improve our programs. And Fiona McEnany is now volunteering for us. She's a current MPH student, and I really appreciate you there. So we have a very small agency. These are my 2 colleagues, Juan Nesson and Ryan Richards, and I have them posted just for increased recognition, because it's true, a lot of people don't know about our agency. We started out, our original name was the acronym was ACORN, but it was AIDS Community Resource Network. And then somewhere along the line, a few years in, we actually changed that name to A Community Resource Network. And that was mostly because of stigma. Our agency didn't want to have the word AIDS in the title. Our clients didn't want the word AIDS in the title. Obviously, that's changed because now we're the HIV HCV Resource Center, but there's still a lot of stigma that our clients feel, and stigma is going to be a recurring theme in this presentation. So we all multitask. Wanda is our New Hampshire case manager, and she has about 30 low-income clients living with HIV, and we try to make sure that they get access to housing, stable housing and medication. And Ryan is our Vermont case manager. But both Ryan and Wanda also work with people who use injection drugs. Ryan spends a lot of time at the syringe exchanges, and he became a certified application counselor, so he's able to help our clients sign up for insurance. Wanda ran a counseling program that we offer for our clients since 2011. So, and then I think Sarah probably mentioned already the main things we do: case management, HIV and hepatitis C testing, risk reduction counseling. We're trying to replace that with case management. I just wrote a grant application to the Vermont Department of Health to be able to offer case management services for people who inject drugs. We think that's going to help people increase their connection to care. Because the counseling program was great for what it was, but we couldn't really follow people to the extent that we want to. So we're hoping that they're going to let us hire a case manager specifically for people who use injection drugs. We have 2 syringe exchange programs. The Good Neighbor Health Clinic program has been in place since 2006, actually, and it's a great program. It was working so well. I like the medical model where we have the syringe exchange embedded in a medical setting. Good Neighbor Health Clinic is available to uninsured and underinsured people, so people can come in and get free services. That we decided to open another program in Springfield, which was a town of great need, and we really worked to get the program into the Springfield Health Center, and we were lucky that they agreed. And again, it's easy for people to connect with medical services, having the syringe exchange embedded in a medical center. The Springfield Health Center is a federally qualified health center, part of the Springfield Medical Care System. So again, people can get free care if they need to. And then we're working in collaboration with Project 439, which is a group of very motivated Geisel students to reopen their syringe exchange in Claremont. And as an aside, we're also looking at Windsor. So we think there should be a syringe exchange in every town, because most of our clients in all of these programs live just within walking distance of our program. So that's the Good Neighbor Health Clinic. It's a very friendly place. You can walk in and you feel like you're in somebody's living room, and that kind of destigmatizes for our clients the experience of going to a syringe exchange. Nobody else in the waiting room has to know that they're going to a syringe exchange. They ask for me by name, or they ask for Ryan by name. It's very discreet. And similarly in Springfield, they can actually come into the exchange room and bypass the administrative office entirely. And if the door is closed, they just wait until that client leaves, and then they come in. The reason I like the medical model so much is that clients can get on-site care. So we have clients coming in with abscesses or other health problems or fevers, and they're often able to see the physician on call at, especially a Good Neighbor, and that works out really well. Our clients a lot of people have had really bad experience at hospitals, and some people simply will not go to local hospitals no matter what. They say, I heard a story recently of a young woman who said that when she had an IV in at the hospital, I'm not sure if it was after an overdose or I can't remember what the circumstance was, but she said that when she felt like when the nurse found out that she was a person who uses injection drugs, that she ripped the IV out. And there's just a lot of stories like that from clients. Do you have a question?
Yeah, real quick. So when they come here too, if they're like on probation or parole or anything like that, is it like if they were to go to the emergency room and please get involved?
No. So that all of our and this makes it harder to actually follow up with people. Our syringe exchange programs are anonymous. So that's a good segue into the next slide, which is what happens in the typical intake when somebody comes in for the first time. We give them a unique identifier that's not their name. And if somebody picked up their card off the street, they wouldn't necessarily associate it with that person, although it does have part of their birth year in it. But so they don't have to say their names. A lot of clients do say their names, and some people will even come in and say, oh, do I need to show my ID? No, they don't have to show their ID. We just want them to feel comfortable coming into the exchange. So we track them with their unique identifiers. Unfortunately, for many years now, we've been using Excel to track our clients, and it's just getting way too complicated. And we just found out last week that the Vermont Department of Health is actually going to purchase this a software program specific to syringe exchange for us called NEO 360, and we're really happy about that because then when somebody comes in, I can just put their ID number in, look up their hepatitis status, I can see exactly what's going on. It's so hard right now, it's hard to remember different people's hepatitis statuses, and using Excel, it's just hard to track people, harder to track people. So I think this new software is going to really help us along. In addition to case management, we're really going to be able to get a better handle on what the needs of our clients are. When people come in, we talk to them about the law. That both New Hampshire and Vermont now have Good Samaritan bills, and which protects people from arrest in the case of overdose. So if somebody overdoses and you call in that overdose, in Vermont, the person who calls in the overdose and the overdosing person are both protected from being arrested for either drug possession, drug sales. They can't have their property seized. In New Hampshire, the bill is more narrowly worded, and that bill just passed a little over a year ago. Vermont's had its bill in place for a long time. So in New Hampshire, people are protected from drug sales. So we're trying to get the word out that you are protected if you call in an overdose. We really want people to call 911 when somebody overdoses, because especially with the potency of the fentanyl around nowadays.
Even if they're on parole or probation.
Yes, exactly. And they don't know that, and that's an ongoing discussion that we have with them. And also in New Hampshire, that law hasn't really been tested a lot yet. So when the Good Samaritan bill just originally came out in Vermont, I had clients whose naloxone was getting confiscated by law enforcement. Our local law enforcement were taking the naloxone, saying that shows intent to use, and trying to use that in court. That doesn't happen anymore, fortunately. So it's just a process of educating law enforcement and educating clients in kind of a long process. So we're hopeful that in New Hampshire now that this bill has been in place for a year and almost two, that New Hampshire law enforcement is also, I guess, acting to the letter of the law. The Vermont paraphernalia law has been in place since trying to remember, 1999, I think. Vermont has had syringe exchange for a long time. Our original program at Good Neighbor opened in 2006. I wasn't there yet, but so that protects people carrying needles with drug residue on the day of the exchange. So if people are bringing encourages people to bring back their needles to the exchange. And New Hampshire finally passed their bill just a year ago, enabling syringe exchange in New Hampshire. So that's a great, that's great that syringe exchanges are now popping up in New Hampshire because it's much needed. So also when somebody comes in, we talk about their hepatitis status. We ask them if they want to get tested for hepatitis and HIV. We don't always do the testing on site, but we do offer it because there's a lot of stuff to do when somebody comes in for the first time. Plus, there might be people waiting in the waiting room. I personally always prioritize overdose prevention. I'm always trying to make sure that everybody has Narcan. Even people who aren't using opioids are often in contact with people who are using opioids. So it's important to get the naloxone out there. We talk about drug use. I don't pump people with questions about their drug use, nor do I have a very complicated intake survey because I feel like it discourages people from coming in. I'd rather get to know them over a period of time and gradually talk about drug use. And so I'm looking forward to tracking all that stuff in my new software when I get it. We have a whole variety of harm reduction supplies, several kinds of needles. We have different sizes of sharps containers, tourniquets. We have color-coded cookers, which are these little metal containers that you can heat your powder drugs in, and if people are using together, they can distinguish their cooker by the color, so they're not sharing the cookers and the ingredients in the cooker. And that's especially important to avoid acquiring hepatitis C, which can be passed through water for injection. We have a ton of information on hepatitis and HIV, safe injection. We're always talking to people about referrals and medication treatment programs, residential programs. We have some homeless clients. We try to work with them to get housing, but we're big on referrals. So I think our programs fill a really important, I guess, harm reduction bridge from active drug use for active drug users. So these are the Vermont laws that I just mentioned. There's a picture of our Springfield exchange. You can see the color-coded cookers. We have the naloxone, the different educational information that we have for people. We often give people hepatitis fact sheets, and sometimes we'll fold them up and we'll put them in boxes of needles that people can take to their friends. We encourage secondary exchange, which is when people come in and get needles for other people. We encourage people to use one needle for one injection. So, and all of my data are coming up is from fiscal year 2018, because that's an easily reportable year that's closest to the current time. So altogether, over the past 12 years, we've had 448 clients, unique individuals in White River. We have now 83 clients in Springfield since 2016 in March. Any given quarter, we see about 60 different people. So our needle exchange rates could be better. In White River last year, and we had 24,000 needles returned to us, and we gave out 61,000. In Springfield, we actually exchanged more needles in Springfield, even though we have fewer clients. We're only open once a week than we do in White River, amazingly. But Springfield has a great need, and we know people in Springfield that are high volume exchangers. So and our return percentage rate is, we don't feel like it's problematic, but we would like to increase our return percentage rate, especially when we report this data. When the public sees it, they become very concerned about the number of needles that are not being returned to the exchange, especially when needles are found on the street. And it makes sense, because nobody wants needles on the street for like little kids on your way to school. It's a big problem in Springfield right now. We're always trying to make sure our clients either return their needles or dispose of them properly. We talk about safe disposal with all of our clients. We give them the sharps containers that they bring back, but also they can put their needles. It's actually legal in Vermont to put your needles in a hard plastic container, tape it on the top, and write "do not recycle" on it. And some people do that. Some people dispose of their needles in their household garbage, which is actually okay to do. We really encourage them to come back, but we're not going to make a one-for-one return policy. We want to get the needles out to other people that aren't coming to the exchange. The high volume exchangers, we expect those people to bring their needles back. So if we're going to give somebody 1,000 needles when they walk in, or even 1,500 in one day, we want them to return them, and we insist that they do. And they usually do. They'll take an 8-gallon container like that home with them to the house where they're using. They'll fill it up and they'll bring it back. And actually, when the second week we had our Springfield exchange, somebody called on the phone and said she wanted to bring a tote in of needles. And I thought a tote, like a little tote bag. And it turns out that she was talking about a plastic tote that, like this size plastic tote, that it must have had 6,000 needles in it, that she had saved up over a period of years. There was nowhere to dispose of them. Some of them were hers and her friends from when she was using. She's now in a treatment program. And some they had found on the street over a period of years. So she just had this tote sitting in her basement with nowhere to go, and so we took the tote and got rid of it for her. So at Good Neighbor last year, we saw 127 unique individuals for 319 visits. About 2/3 of them are Vermont residents, 1/3 is New Hampshire residents. We have a lot of people from White River, Lebanon area, and then there are people that come from 30 Upper Valley towns. In Springfield, similarly, most of our clients in Springfield come right from Springfield and within walking distance to the exchange. We have about 20% of clients that come from other towns. And I mention these at public forums too, because I think people, when they're, a lot of people are concerned about having syringe exchange in their town, and they're worried that people are going to come in from other towns and create a ruckus, or that they'll be bombarded with people from other towns. But this data indicates that just doesn't happen. Most of the people at the syringe exchange come from the town where the exchange is located. So the ages of our clients are White River clients. Most people are in their 20s and 30s. Springfield skews a little bit higher. We have a larger percentage of clients in their 40s than we do in White River, and we have a smaller percentage of clients in their 20s than we do in White River. Client gender is slightly more male than female at both locations, and that's just for last year. If we took the data from 2010, it would be very different. Back in that day, it was much closer to less than 1/3 women and 2/3 men. So for whatever reason, it seems like it's getting to be more even now. I did a similar version of this presentation in 2016 and had this slide, and this slide is based on just our observations of people. It's not hard data, but we would have estimated that about 70% of our clients were using heroin just based on what they told us. Maybe 60% of them were using oxycodone or pharmaceuticals when they could get them. 30% were using Suboxone or Subutex, and either they were in programs or they were purchasing diverted Suboxone or mail ordering it from Florida. Maybe 20% used benzodiazepines. A lot of those are actually prescribed for clients. 20% cocaine. Back then, it was maybe 20% fentanyl. Fentanyl was just becoming bigger, and just a few meth users, and some people using hormones and steroids. And I realized that this is all anecdotal, and as my son likes to quote, the plural of anecdotes is not data. So I'm aware that this is, just wanted to put that out there because I know you're all data people, and this presentation is very sort of experiential information, although there is some data. Anthropology. Yeah. So fast forward to 2018, people are still using heroin. People use the pharmaceuticals when they can get them, but heroin is a lot cheaper. People still use benzodiazepines. More people seem to be using cocaine now. I just hear more about it. I've got some people that are only using cocaine, and they talk about it, and so that sort of swayed me to think that there is more cocaine use, but I actually think there is more cocaine. A lot of people are using fentanyl, and people are seeking out fentanyl. And I wonder what fentanyl is doing to the journey of recovery for people, because fentanyl is so potent. People want that over heroin now, and it gives them the most rush feeling. And so I just wonder about the connection between that and, say, methadone. Will methadone actually take care of those fentanyl urges the way it does to maybe heroin, or Suboxone probably won't. But I don't know. I'm just curious about that. That could be a good research study. A lot of people.
There are multiple uses.
Yeah, multiple. Yeah, a lot of people are using a lot of different things.
Do you ever get calls from from, like directors or nurses or anything in clinic to help, like, give patient referrals or keep it advertised, like put posters up so that people are aware that you even exist?
Well, yeah, we do. We work with Dartmouth. We work with Daisy Goodman a lot. I refer pregnant clients to her program, and I think their program knows about us. So I think the people who are actually actively using injection drugs, a lot know about us, and I think a lot of the recovery, all the rehabs know about us. And I go give talks at the rehab, let's say on hepatitis and HIV.
Just to comment on that, so when I first knew of you guys, maybe 6 or 7 years ago, we were at the River Mill, which is on Mechanic Street, about 2 streets down from where these guys are located. And colleagues at the Addiction Treatment Center, when I said, "Oh, did you guys know that there's an HCV Resource Center right down the street?" And I got a blank look. And did you know that they actually run the local needle exchange? Did you know that that's happening locally? And I got a blank look. So that was from our colleagues in addiction treatment. So,
And I never ever see anything about, like, I feel like there should be more advertisement around it and places like methadone clinics and stuff, but there's not.
Yeah, interesting that you said that. Because I've always gone back and forth on to what extent to advertise. Like when we started up in Springfield, we just did word of mouth, and I made little startup cards, and I had White River clients photograph them and text them to their friends in Springfield. And then, like for the first 2 weeks, there was nobody, and then all of a sudden we started getting people showing up. And actually, there's a Springfield Facebook page right now that found out about our program that didn't know about it, and some of the comments are, "Well, why don't they advertise? Why didn't we know about this program?" And I'm like, well, there's a fine line between keeping low profile and advertising and getting a community uproar, because a lot of times when communities find out that there are programs in their community, they don't like that. There's so much stigma, and we don't want our clients to have that directed towards them. So it's a hard.
I think it should be in the clinic, not
Yeah.
like,
Mm-hmm.
at Walmart
Right.
or like, I don't think that, but I think that
Right.
it is so important, the amount of people it means clinics are still using.
Yeah. Oh, I know, and we see that a lot. So right now, methamphetamine and bath salts are just getting to be much more popular than they were before. And again, my perception can be somewhat skewed because among my Springfield clients, I have a big group of bath salt users, and they all live together, and I'm sure they sell bath salts. There's a lot of bath salt activity going on, and I know some of our White River clients will go down to Springfield to that location and use the bath salts or buy them and bring them up. So I think it's very concerning. And then, so my next slide is preliminary results of our survey. We've only had 8 full responses. I know that's a very small number of people. I'm aware of that, but I'm just using this slide to indicate the diversity of drugs that people are using. It's just weird. It just happens to be strange that the first 8 people that have answered this survey all use, 7 out of 8 of them use bath salts, and 6 out of 8 of them use fentanyl in the past year. 5 out of the 8 of them use meth. 4 out of 8 have said they use GHB or MDMA, and 2 out of 8 dextromethorphan. So, and then 8 out of 8 of them used cocaine, marijuana, and heroin within the past year. So is the result skewed because I just happened to encounter the meth users that answered the survey? It happens that 4 of them are from White River and 4 of them are from Springfield. I don't know, but I'll be interested to see future, once more people start filling out the survey, exactly how the drug use changes, if it does. But I still think even with this very small sample size, this is a good indication that people aren't only using opioids. There's a lot of mixed drug use.
Laura, is this survey being worked into intake? So that
Yeah, it is. So we're not right now, we're waiting for Neo 360
Yeah.
because
There's
we're going to do it all on the computer.
It will do that?
It'll do
You'll be able to collect those data?
Yeah,
Okay.
it's going to be so much better
Great.
for information seeking. So lots of people using, or a few people using many different drugs. Another cause for concern, those 8 people answered the age of their first use, and one person said 12. So 6 people out of 8 started using drugs before the age of 16. And I find that in Springfield, again, anecdotally, a lot of people in Springfield talk about using injection drugs starting at the age of 14. I had one young person who's actually not that young anymore, but was saying that how he started, he said that he used to walk past the small area where there were people hanging out using heroin with his mom, and he was 12, and he had the same name as one of these older guys, and they sort of bonded, or they would chat over the name, and by the time he was 14, he was injecting heroin with them. So I see that a lot, conversations about, with clients about when they started, how they started. A lot of people started with friends, and it was normal for their peer group. So one person told me that when he started, he was in high school with his friends, and they just tried everything. They tried whatever they could. They didn't distinguish heroin or marijuana or hallucinogens. They put everything sort of on the same level and tried what they could. And then of course some of them kept using it and some of them didn't. But and then of course I have a lot of clients that have originally prescribed pain medication that turned into a big problem. And people often cite traumatic events or traumatic circumstances in their lives for why they started using. We have a lot of generational drug use in our client population. Sometimes I have a mother and 3 grown sons that come in all together. I have another mother and a daughter, a couple mother-daughter couples, an uncle and a niece. There's intergenerational family use, and quite a number of those people. There's people that have co-occurring disorders who are already on other medication. I have clients that are taking medication for bipolar disorder, PTSD, depression, and they're also using heroin or fentanyl on the side. And they don't always want to tell their providers, obviously, which makes it hard. We were always trying to encourage clients to tell their providers about their drug use, obviously, especially pregnant clients, because it's going to come out, especially with pregnant clients, it's going to come out, but not everybody does. And then, as you might expect, a lot of our clients have neglect and trauma or abuse in their background. So we have clients, we talk to clients all the time about medication-assisted treatment, about treatment programs, about abstinence-based treatment, trying to assess whether they're interested in treatment. Most people say they are interested in treatment. Not all of them, but quite a lot of them are, and for whatever reason, they're not currently in treatment. So one thing that happens to clients is that, and I think in sort of an inherent conflict in the treatment programs, is a lot of these programs are for-profit programs. And if you can't pay your fee, they kick you out, and they call it financial detox. And then the client will come back to the exchange saying they have been financially detoxed from their program, and they'll be on a high dose of methadone. They'll take them down, taper them down within a week, and then they're back to the needle exchange buying heroin or fentanyl. And I've seen that on a number of occasions. Some programs take Medicaid for the medication fee, but not for the program fee. So sometimes the clients have to come up with a program fee. It's too much. They can't do it. Transportation is a huge impediment to accessing programs and meeting the program requirements. We have actually quite a number of clients who have jobs, and it's hard to be in the programs around their work schedule conflict, childcare issues. Some clients are worried about confidentiality. They don't want to be in programs where they have to share stories with others in groups. Some clients have been kicked out of their programs for other drug use, including marijuana. So there's some medication-assisted treatment programs that will kick you out if you use marijuana. I think from a harm reduction standpoint that marijuana is actually the least of their worries. But I know some programs have different requirements, and so I think it's unfortunate that they get kicked out for using marijuana, because then they come back to the syringe exchange and then they're using the street drugs. Sometimes people say that the amount of medication is too low and they supplement. So I have quite a number of clients that are in programs, but they're supplementing on the side. Sometimes the amount of medication is too high and it leads to lethargy or fatigue, and they stop taking it. And then we have a whole subpopulation of people that are self-medicating with Suboxone and almost entirely using Suboxone only, and they're either buying diverted Suboxone or mail ordering it. A lot of people still inject Suboxone, and I have some clients that don't want to inject Suboxone. They do it, but they know they shouldn't. They know intellectually that if you take it sublingually, it lasts longer in your system, but they want that feeling. They want that feeling of the rush. And I have heard about clients injecting water when they don't have anything. That actually happens. Some clients actually say that they're addicted to the needle. They can't stop using the needles. When they wake up in the morning, they're feeling kind of sick, and then if they inject the Suboxone, it gets in their system. They feel faster. So for whatever reason, there's a number of people that are injecting Suboxone. Any drug is injectable. It's like the strips. There's always a way to tinker with the binders or whatever the substance is made up of to make it injectable. So we have a program where we've helped people pay for their medication-assisted treatment over a period of either of 1 week to several months. And we're very selective about who we help. We prioritize homeless clients or clients that have just been released from prison, because we don't want them to go back to street drugs, so they'll come into the exchange. If their Medicaid situation isn't taken care of yet, or if they're sort of homeless between states, we'll pick up their program fees for them during that time that they're applying for Medicaid, which we help them do, or other insurance. Pregnant women as well. Even though pregnant women are prioritized for treatment in the treatment programs, it doesn't always work that they get right into the treatment program. And we had a homeless pregnant woman that was living in a car without Medicaid between several states, and it was really hard to get her into a program. There were several social service agencies working together to do that, and the best result happened. I think she moved back to her home state and had a baby, and who was now being taken care of by her aunt. So that it ultimately was a good result, and she was able to be in a medication-assisted treatment program while she was pregnant. So far we've paid for 45 clients at various levels of payment, and that program is funded by grant funds, town funds. The city of Lebanon funds that program for Lebanon residents. And I wanted to mention, we also have a counseling program. This is a program we're hoping to replace with case management, but this program has been great for our clients. It's a part of the CDC's diffusion of effective behavioral interventions. So it's an evidence-based program rooted in cognitive behavioral therapy and social action theory, designed to reduce substance use risk behavior and improve mental and physical health. It helps people set short-term and long-term goals, problem solve, communicate, and develop an emotional vocabulary, a way to express your feelings. A lot of people have a lot of trouble expressing their feelings, and it has even this. When I first saw the program, I thought, oh, it seems so simple. It has a feelings thermometer, but actually, people really like the feelings thermometer. It really helps them identify their feelings. And so Wanda, our New Hampshire case manager, who happens to be a LADAC, has worked with like probably 126 people through this program since 2011. And after the 5 core sessions it goes on, you can have 12 more optional sessions. And You don't have to talk about drug use, but you can. And it was an incentivized program, which is probably why we had so many people doing it. But people really seem they seem to like the program, and the surveys, the before and after surveys, did indicate that they did learn something from the program. So we're happy we were able to offer it. So here's a typical day at the Syringe Exchange with some clients in White River, taking these boxes of needles, and this is a pretty large amount of needles to give somebody in one time, so we do expect them to bring them back, and they do bring them back. Because we won't give high volumes of needles out unless clients bring them back. We have a targeted HIV and hepatitis C testing program. Syringe Exchange originally was developed under the auspices of HIV prevention. There's a big Yale study in 1993 that showed in the area around New Haven where the Syringe Exchange program was established that actually HIV transmission rates decreased. And so we are working really hard to get people tested and to get people to learn their status. We don't have a lot of clients living with HIV, and the clients that we do have living with HIV at our Syringe Exchange are virally suppressed. So they're not going to be the ones that are, well, actually, I shouldn't say it that way, because it's unlikely that they will be sexually transmitting the virus to somebody else. But the blood-to-blood transmission for HIV is a little different and not as known, actually, if they're sharing needles, but they hopefully are not sharing needles. So this testing program, we train people to bring in their friends for HIV and Hep C testing, and it's social network testing. It's another CDC approved program based on the idea that viruses travel through the social networks of people, and people in the same social network engage in similar risk behaviors. So we worked with a lot of people to get them tested.
Laura, can I just comment on why that part is so important? Is we're actually seeing in the past several years there's been an increase, a market increase in the number of folks that have been testing HIV positive. So we're in New Hampshire, so we're on a trajectory up. And so it's really, really important. The social networking testing is very, very important currently.
And that's how they nipped that beginning epidemic in Austin, Indiana in 2015 in the bud by doing this social network testing model. They brought in people from the New York and Vermont Department of Health and other departments of health into Indiana who went through communities and incentivized testing and got all these people tested. And so ultimately, I think there were 183 new infections. So it could have been a lot worse. And it was made worse by the fact that the governor at the time, Mike Pence, took a whole year to authorize the development of Syringe Exchange in Indiana. So that was unfortunate, because it could have been even, they could have maybe even gotten it faster. But it's so strange that ever since I've been doing this work since 2010, I still hear the same information from injection drug users who say, "Oh, who believe you can get hepatitis from yourself." And I don't know who is perpetuating that myth. And sometimes I even wonder if it's members of a medical establishment, because they don't want people to reuse their own syringes. I don't know, and I'm not saying that it is. I'm just saying there's a lot of confusion out there. So we have this fact sheet that we give people from the Allen Franciscus Hepatitis C Support Project, which is this very specific thing, and it shows studies that indicate that hepatitis can live in the barrel of a syringe given the right temperature, volume circumstances for 63 days. And that is eye-opening for clients. Like, it can be reconstituted from dry blood on a surface. It can live for 6 weeks. It can live in water for 3 weeks. A lot of people share water for injection. So we're really trying to get the word out to clients that you don't need to share needles to acquire hepatitis C. It's a hardy virus. And so we've had several clients who have tested positive for hepatitis C antibodies, but they're pretty sure they've never shared needles. And so that ended up having people bring in their friends for testing because they realized, oh no, I might have it because I shared water, or I shared my tourniquets or cookers, and so we had a big group of testing that we did when that information got out. So in the past year, we've tested 38 people, and 15 tested positive for hepatitis C antibodies. So that's kind of a high. 39% is kind of a high rate. We have quite a number of clients who think they have hepatitis C. They can get viral load testing appointments, follow-up testing appointments, because they have to. 15 to 25% of people clear the virus on their own, and then the others will have the virus, but they need to get a viral load test after they test positive on an antibody test. And we're losing these people. There's confusion about hepatitis C status, and we're not the only agency that's losing the people. It's the other aid service agencies who do syringe exchange too. So I keep wondering, every year I write grant applications, and I'm like, we're going to learn the hepatitis status of all of our clients. But the fact is that there's so much confusion from our clients about their own hepatitis status that we have not learned the hepatitis status of all of our clients, nor have we gotten our clients to get into the follow-up care. Only about 20% of clients who test positive end up going for their viral load test. And a lot of clients say they will not go to hospitals to get a blood test because they just don't want to be mistreated. And that's happened a lot. And I have occasionally driven people. And when we do, hopefully when we do offer case management, we will be able to drive people to get their tests even more. Some people don't have transportation. Some people are just busy. They put it on the back burner. They know it's a long-term virus. Some people, their drug use, family, job, kids take precedence. Some people say they can't go into New Hampshire to go to Dartmouth, for instance. And I see them in New Hampshire. Some people have concerns about side effects of treatment, or they're concerned that providers won't treat hepatitis C, or their insurance won't pay for treatment. So there's just a whole bunch of reasons that they cite for why they're not getting their follow-up testing. There is hope for the future. There's national guidelines in Vermont, guidelines that are changing to encourage providers to treat hepatitis even when people are actively using injection drugs, and not to wait until people have advanced scores on the fibrosis scale to treat hepatitis. The new treatments are shorter duration, they have fewer side effects, and they're more successful. So we're hoping that with these changes in policy and with case management, we'll be able to strongly encourage clients to get their follow-up more than they have been. So I'm segueing into our naloxone program. We've been distributing, we were part of a pilot study for the Vermont Department of Health, and we've been distributing naloxone since 2014. So I just took all the data, and we've given out over 1,000 doses of naloxone to 370 individual clients, and some of them have come back for return doses. Most of the clients who pick up naloxone are our syringe exchange clients. Some of them are family members of opioid users, or school nurses, or emergency personnel. We talk about overdose prevention all the time with our clients. Don't use alone. Gradual tie release. Don't just release your tie all at once so the drugs get into your system so quickly. Do a test shot. Just check the potency. Be careful if you've been abstinent for a while. However, that doesn't always work, obviously, and people still do overdose. A lot of people do use it alone. Some people want that initial rush, so they just release their tie all at once, even if they theoretically know that the harm reduction approach would be a gradual release of tie. Obviously, people lose consciousness before they're aware that they're overdosing, so they can't help themselves, especially if they're alone. The ingredients of bags that they purchase within a bundle can all be different. Somebody was telling me that she had one bag that she thought was cut with Wellbutrin, and another bag that she thought was cut with like cocaine. So even if you do use one bag, it doesn't guarantee that your whole batch of drugs is the same ingredient. So if you do a test shot, it might not reflect the potency of the subsequent shot. So I guess that's why test shots don't work. Some people say they know their dealer, they know what's in the bag, the dealer tells them, which does not to me seems a little risky. Some people say they can see if there's fentanyl in their drugs, so the hue is slightly yellower. I don't think you can always see that though, because if you could, you would be not as likely to overdose. We've often talked to clients about whether there's a duty to warn. Most clients say that it's their own responsibility to know what's in their drugs. Some clients say that they feel like dealers deliberately spike drugs that cause an overdose to have people flock to those drugs. So we've had 144 overdose reversals reported by 80 individuals. And then we have a whole list of questions that we've asked, but not everybody responds to every question. So out of 93 responses in that circumstance, we've had most people say that it was their friend or a stranger that was nearby who overdosed. So people are using drugs together in private homes. Interestingly, men are overdosing 2/3 male to 1/3 female for people who actually overdose, and that's 95 responses. Most people who overdose are in their 20s and 30s. The majority of people were not recently in treatment or incarcerated, so that I think that just speaks to the potency of the drug. This is sort of good news. The police EMT interaction was either neutral or positive in 23 out of 27 responses, and that's what we want. We want people to want to call 911, to have a good experience with law enforcement, so they're not afraid to call 911. So of people who report overdose, I'm curious to see if women reported overdose more frequently than men. For some reason, in conversations with women, they often have more detailed reports of the overdoses. So I was just looking at the data, and they don't. I mean, they do, but not that much more frequently. Also, who calls 911? Women call 911 at almost the same rate that men call 911. So, but in the 144 overdose reversal reports of whether 911 was called, it was called in 94 of those circumstances, which is 65%, and it was not called in 50, which is 35%. So we're still not getting data really for the 35% of the people that don't call 911. People don't call 911 because they're afraid of being arrested, and a lot of people have a lot of legal problems, as you can imagine. So they don't call 911. This is the chart that's like the cumulative data from 2014. But back in 2014, I'm pretty sure that there were about 1/3 of people that call 911 and 2/3 that didn't. So it's actually kind of nice that that's reversing, that people are more comfortable calling 911 now. But we're still, and we think that we're only getting reports of we think that there's so many overdose reversals that happen without being reported to us. We don't know how, we think at least 2/3 more overdoses are going on that we don't know about. Oh, darn, something happened with my chart, but I'll just say that in Springfield, out of 27 overdose reversals last year, we had 3 of them were for White River clients, and all the rest were Springfield clients. And I was trying to wonder why that could be. And was it just that Springfield clients reported more overdoses, or was there a skewed result? Because there are a couple individuals in Springfield that overdosed a lot, and so they got captured in the data that way. One actually, 10 times. Some of this data is duplicated too. We try to weed out the duplicated data, but since different people report to us, we're not sure, and it's anonymous. We're not always sure whether, they're reporting the same overdose. Is there more fentanyl in Springfield? I think there is more fentanyl in Springfield. To what extent does that affect the overdose? Is it stronger in Springfield? I think it is. More mixed drug use. There's fewer medication-assisted treatment programs, certainly. The closest one is in Bellows Falls, which is actually driving distance, and not everybody can get there. So up here, we have a plethora of medication-assisted treatment programs. We're lucky. And I know you can't really measure hopelessness, but I can just say again, anecdotally, that a lot of my Springfield clients feel not a lot of hope in their lives. And in general, the White River clients are they're more connected to resources than the Springfield clients. Springfield clients tend to be poorer. There's a lot of stigma against drug users in Springfield. Not that there's not a lot of stigma against drug users everywhere, but in particular in Springfield. I'll just go through this quickly. Another cause for concern is the past in 2017 and 2018. And quite a number of people have said, 17 people have said that it took more than 5 minutes to reverse the overdose of naloxone. It's taking multiple doses now. So that speaks to the potency of the drug, the fentanyl. We just got fentanyl test strips. We're very excited about it. According to our colleagues at Vermont Cares, when they did a pilot study on fentanyl test strips, we found that people actually did change their behavior when they found that there was fentanyl in their drugs. They either used alone less frequently, used with someone more frequently, had naloxone on hand, injected more slowly. So that's good news, and we're looking forward to getting our fentanyl test strips out there to our clients so they can. It won't tell you the amount of fentanyl in your drugs, but it will tell you that you have fentanyl. And I just want to mention, finally, stigma being directed towards syringe exchange in Springfield. There's a Facebook page called Happenings in and Around Springfield, Vermont, and the administrator of the Facebook page started writing about syringe exchange, not realizing that there was a syringe exchange. And then they're all, Facebook, everybody's like, all the vitriol coming in. And so she posted that there were 3 needles picked up in a parking lot. And how is that needle exchange working out? And then this was some of the response from the people whose names were very obvious, who were not anonymously posting. They were posting under their real people. They don't care. Addicts do what addicts do, but the compassionate pansies don't see it that way. You're asking people who have no regard for life to use common sense. Let me think about that. They break the law every time they use it. So why do they follow rules? Please tell me. There's a lot of attitudes like that. And in some ways, it's very understandable that people are afraid in Springfield. They're afraid for their children. They're afraid when their kids are walking to school. Those are all very legitimate concerns. But I think the stigma that gets sort of mixed in with that is really hard to combat. And I met with that woman. Actually, she wrote me, and I met with her for 2.5 hours the other day. And now she's a proponent of syringe exchange. So I feel like, yes, that was like one person convinced, which I'm happy about. And she's going to post another long thing. And so finally, I just want to end with a quote. One of my syringe exchange members, he just said the other day, people knew how certain drugs get right a hold of you and don't let go. I think there'd be less drug use and less ODs. And then he went on to talk about stigma and how people don't get help because of stigma. And I just thought that really sort of sums it up in a lot of ways, and how important it is to keep fighting the stigma and keep helping people get access to resources. So, questions?
Thank you. So when they go into, they choose the number of needles that they want.
They do.
There was like some of those maps amount. So how long does it take them to come back?
So they don't all, like, I don't give that big box to somebody who's just walked in the door. Those people I know, and I've known them for years. So I want to make sure they're going to bring them back. So usually if somebody comes in, they'll get either a bag of 10 or a box of 100.
How long does it take the ones that you've known for a while?
It takes a while because they have to fill up their 8-gallon sharps container and then bring that whole thing back. So sometimes it can take a couple months to bring it back. But they do, those people, the high volume people, bring back their needle pretty regularly.
And for the reasons why with the whole Hep C thing, you don't ever get the answer that I feel like one of the biggest answers wasn't on that was the whole question why, and that would be that if somebody was to find out that they have Hep why they wouldn't want to go look any further into it, is because they know they have it, or even if they feel like they have it, they probably just kind of give up hope, like, if you don't care, I have it, like.
Well, I think nowadays that they know people who have gone through the treatment successfully, because now it is curable, as opposed to even 6 years ago when the treatment, they had still the ribavirin and the interferon, less of side effects, and now they take Harvoni as a much shorter treatment. And I haven't heard that actually. I've heard that they just want to put it on the back burner. Also, a lot of medical professionals will say, oh, you don't have a high viral load, just wait. And which really, the treatment protocols in national treatment protocols are just treat everyone now, regardless of their fibrosis scale, or because you can get rid of it.
I thought that you had, my understanding of it from what I've heard from a lot of people is that you cannot just go get treated, or that you have to be sober for pretty
That's the problem.
amount of time.
9 months.
They don't want to do that.
They don't want to do that. No, but now in Vermont, they're trying to make it so Vermont insurance is going to hopefully pay for people who are still injecting street drugs. And, I mean, I understand, and also the treatment protocol, the sobriety aspect made sense before because the treatment was so grueling. And who wants to, like, if you're trying to face a grueling treatment with a lot of side effects and you're using heroin on the side, your chances of adherence are not so high. Whereas now the treatment is short, it's effective, and it doesn't have the same kind of side effects. So even if you're still using heroin, you could probably do the hepatitis treatment and have it be successful. And I think people do act in their own best. Like I know there are people that don't care who they share with, or if they acquire hepatitis. There are some really desperate people who are just to the point of not caring. But the majority of people, and the majority of our clients, I feel like, really do care, and they don't want to have hepatitis, and they'll take precautions to avoid getting hepatitis when they learn about hepatitis transmission. Yeah, but there's so much misinformation, and medical providers will say different things, and people are very concerned. They're like, I think I have the virus, or my doctor told me I cleared it, but then another doctor told me I didn't. So I hear that a lot, and I'd like to get to the bottom of that. And I think that is what is impeding us from understanding our clients' hepatitis status. Any other questions? All right.
You want music? Or? Okay. Thank you very much,
Oh,
Laura.
thank you, Laura.
All right. So awesome.
All right, our next presentation is November 15th. Again, Kate Jankowski and Aaron Knight will be coming to present on parental opioid use and childhood trauma. So we'll see you all, hopefully, November 15th. Please spread the word, share it with some of your friends. We'll be sending out an announcement about that within the next couple of weeks. So we'll see you in a month. 2 months.